Hello, everyone, and welcome back to class. We are in week 4 now, and this is our first screencast of the week, and we're looking at chapter 11. So, this chapter is Quality of Life and Coping with Chronic Illness and Disability, a Temporal Perspective. So, some of these chapters that we're going to be exploring may be challenging at first to see how they potentially directly relate to what we do on a day to day basis as a physical therapist or as an occupational therapist. And I struggle with that myself too, as we kind of explore the chapters in this textbook. Many of us may not have experience in these areas, and I think the general purpose is, and what we're trying to do here at the University of Medical Sciences, Arizona, is to see the perspective of the patient across all domains, all potential needs that they might have. A lot of times, if I work with somebody and I'm working with them physical therapy basis, and this is an individual that has now developed a chronic health condition, a chronic disability, I may work with them for a short period of time trying to maximize their function. How are they able to walk? What assisted device do they need? Is there any strategies that are needed to help them get in and out of bed? What kind of help do they need to get out into the community? Things like that. But that may be only focused that kind of mindset on certain individuals that are maybe retired, older. What about an individual that is in their 40s or 50s who's had a traumatic brain injury, or somebody who maybe has lost both legs below the knees due to diabetes? So these individuals may still want to contribute to society in different ways through work and through their social interactions. And I think sometimes these things we don't necessarily think about. So we're going to explore different things. And that's kind of what we're looking at here in this particular section, the quality of life and coping with chronic illness and disability. And again, we as physical therapists and occupational therapists may not have all the answers, but we may be able to refer them or talk about practitioners, professionals that could help them with certain issues. All right, so what is quality of life? We all have a perception of that. Quality of life is a prominent and central concept in our field. We want to maximize that. We often link quality of life as a rehab goal and an outcome, and we want to do so in a way that's meaningful to the patient, that helps them meet their community level needs and their personal level needs. Challenges are, what kind of interventions are we able to do within the restrictions of our practice that helps to facilitate those community level clinical interventions? And are there things that we can do that help facilitate coping strategies? And sometimes, again, I think this is an area where at least I, as a physical therapist, may not understand or appreciate what an individual might need. And so hopefully that's the type of thing that is being handled by a social worker or their primary care provider, dealing with coping related to their new paradigm with how their body works. So, looking at community and personal level interventions, managing stressful events, and coping with CID. CID here is chronic illness and disability, or chronic injury and disability. 3 intervention domains: a preventative, so primary prevention or crisis prevention. There is a interventive, which is secondary prevention or crisis intervention, and a postventive, which is tertiary prevention or rehabilitation services. The 3 domains are also noted by their different therapeutic goals, indicators, targeted professional providers, and intervention strategies. Primary prevention strategies. These strategies seek to reduce, harness, and if possible, prevent the occurrence of physical disabilities chronic illnesses, and psychiatric disorders among members of the public, with particular emphasis on those who represent high-risk groups, thus ensuring a sustained positive quality of life. Now, do we oftentimes work with individuals in those domains? Not usually unless you are involved in health and wellness and individuals are accessing you in that capacity. I would think the individuals that are involved in this area may be primary care providers. Secondary prevention refers to those interventions that attempt to directly, immediately, and intensely reduce the effects of an ongoing life crisis and concomitantly promote personal resilience and growth through the crisis experience. So, could this be primary care providers and psychologists? Tertiary prevention, it encompasses those interventions that are geared toward minimizing and, if possibly, reversing the residual impact on people of long-standing and severe physical and psychiatric CIDs, whose onset has been associated with an earlier experience of crisis and its aftermath. And I think this is where we as physical therapists and occupational therapists frequently work. Further analysis of goals of TP or tertiary prevention, as mostly espoused by the fields of rehab psychology and counseling, indicates that they could be further categorized into three of the following domains. Again, here you see some words, rehab psychology and counseling. How does that relate to me as a PT or an OT? Again, it may not. And so we're thinking, okay, vocational counseling, getting back to doing things that you had done previously. These are areas that we're helping out in, but we may not be doing all of the work. So let's kind of explore these concepts here. There is CID minimization, so the chronic injury and disease minimization. This goal is best reflected in those efforts that seek to minimize the CID impact on the individual by reversing the course of the CID and restoring functional capacity, including affected life skills. So we would be involved with that. Typical interventions, a host of PT and OT procedures. So we're a component of that. Other things, assistive technologies to improve sensory functioning, for example, surgical procedures to correct neuromuscular and orthopedic impairments, and use of orthotic and prosthetic devices to improve mobility and manipulative functioning. Skill acquisition, normally associated with rehab efforts to compensate for functional limitations imposed by CID through the enhancement of other not directly implicated abilities and skills. So yeah, we would be working along those lines too. We're involved with, if you can't do it this way, how about if we try this way? When there is modifications, when there's changes occurring, there is often the need to modify and reform one's earlier life goals. So maybe it's more than just everyday function stuff too. More specifically, the goal is to teach and practice specific coping skills and a broad range of life skills through the adoption of psychosocial and vocational rehab. So, somebody's had a traumatic brain injury. What are the things that we as physical therapists and occupational therapists do for these individuals? We may have specific things we do, we may have limited time, but what if this individual was somebody that worked with numbers, did a lot of accounting or something like that, and they can't go back to that type of work because their mind doesn't work that way anymore? What can they do? Environmental manipulation. This goal is normally implemented through efforts directed at modifying and restructuring the environment to minimize the impact of CID-imposed functional restrictions. These efforts are aimed at both the physical environment, so restructuring of a home area, work area, leisure environment, and to eliminate community-based architectural barriers, and the social attitudinal environment. In other words, combating and eliminating the stigma, prejudice, and discrimination stemming from the existence of CID. So we might be involved in aspects of this. How do we change the bathroom to make it safe for somebody to use their toilet and to take a shower? What are those modifications that an OT might make? What recommendations might the PT have for being able to enter into a home? So yes, we as PTs and OTs could work in this area. The social attitudinal environment, we probably don't have a direct role in that. We probably have an indirect role through our political affiliations, political contributions, and just the raising of awareness if we see potential injustices that are occurring. Now, moving on to the temporal aspects of coping with stress and CID. Only scarce literature is presently available on the temporal aspects of coping efforts. This body of literature suggests that these efforts to improve quality of life following stressful situations, that onset of CID, could be conveniently organized into three broad categories. First, a preemptive or pre-impact coping efforts that are directed at potential future stressful life events that range from those whose occurrence spans from unlikely but possible to likely or probable. B, crisis experienced coping efforts directed at presently experienced or ongoing stressful events and crises, including various physical injuries, bodily insults, and psychiatric crises. And C, post-impact or post-event coping efforts directed at stressful life events of the past whose impact still plays a significant role on or in influencing present physical, psychological, and social activities. So as you're reading some of those there, you're probably thinking, that sounds like it might be outside of my area. Well, let's kind of explore them here, and maybe they are, and maybe they're more for the psychologist or the mental health care professional or voc rehab. Preemptive coping can be viewed as the person-level analog of community-anchored primary prevention, which, as outlined earlier, aims to reduce the likelihood of future occurrence of both physical and psychiatric CIDs. Pre-impact coping strategies have been classified as preventative coping, regarded as the most temporally distal from future event occurrence, proactive coping, and anticipatory coping. The extended pre-impact period can be somewhat arbitrary, subdivided into distal anticipatory, mid-range anticipatory, and proximal anticipatory. Preventative coping focuses on those long-term, distant, future-anchored yet broadly anticipated events well before these events are to be encountered. Retirement, age-related illness, long-term medical insurance needs. These efforts therefore reflect coping strategies that seek to address uncertain and mostly unpredictable threats located within a distant future. Proactive coping seeks to avoid or neutralize the occurrence of potentially threatening stressful life events. Proactive coping efforts focus more on minimizing or reducing the impact of such future anchored events. The literature that's available on this is not always clear about such a distinction and presents a rather overlapping view of the two coping modalities. Anticipatory coping refers to those coping efforts that are triggered by environmental and physical cues that indicate that the individual is on a course of confronting an aversive life event. Anticipatory coping is further subdivided into those efforts that confront avoidable and unavoidable life stressors. There is dynamic or impact experienced coping. Coping with ongoing crises may be considered the individual level analog of community aimed SP, secondary prevention, the latter seeking to mitigate the psychic toll mounted by a presently experienced crisis situation. Dynamic coping or coping with presently experienced stressors or crises includes those coping efforts where the individual is said to actively manage the stressful event. They are also described as coping efforts undertaken during directly experienced or ongoing stressful events, often also termed crises or crisis situations. Ironically, crisis is often viewed as the period where coping, including problem-solving ability, has broken down, and therefore normal coping and cognitive processes are no longer capable of achieving the goal of returning the individual to a state of psychological equilibrium. So, what does that all mean to you and me? Maybe nothing. To me, it's an area that I don't work in. I think what we need to be able to do is recognize if somebody is having challenges, if they're having crises, and not be able to label it, or don't even think about, okay, can I as a PT or as an OT, can I do something to minimize it? I think we do what we do, and then we listen to our patients, and if they are willing to open up to us, then I think we can have conversations, especially if we, listen with empathy, if we hear what they're saying, utilize potential motivational interviewing strategies. Don't feel like we have to have the answer, and don't feel like we have to be the expert that tells them what they need to do. Rather, you hear that there's a problem and find out how meaningful that problem is for them, and find out from them through questioning how life could be better if that was addressed. And if it's something that seems meaningful to them, then we can go about the process of finding the right professional, which is probably going to be somebody like their primary care provider or a mental health care professional to help them out. Let's now talk about the experience of crisis. There's been many, sometimes inconsistent definitions of the term. So, general description of it, crisis can be described as a subjective reaction to an acute and an intense variant of a stressful or hazardous life event or experience. It has an identifiable beginning and is time limited, a state most commonly associated with cognitive and emotional disorganization, psychological disequilibrium, extreme vulnerability, reduced functional capacity, and ultimately a failure to cope with the stressful situation using previously familiar and successful strategies. So looking at the clinical literature, it's generated an exhaustive list of chaotic psychosocial reactions that are associated with the onset of crisis. Among the most frequently discussed are those that indicate cognitive and emotional distortions and behavioral malfunctioning. Literature strongly indicates that acute reactions to crisis situations strongly parallel those observed among individuals who sustain a sudden and severe onset of CID, and that have traditionally been referred to as periods of shock, alarm, and anxiety phases. Here are reactions to crises. You probably have seen some of these in your patients, and at least in those who may be able to cognitively express that. I imagine some individuals who've had a severe brain injury, whether it be a TBI or CVA, it may have difficulty expressing these. But what about somebody that's had a quadriplegia, paraplegia event, or somebody that's had a massive heart attack? These could be potential reactions that we would see in those individuals. Types of crises described in the book, the developmental crises, these are crises that are associated with life stages or phases that the individual undergoes rather predictably during the normal course of his or her growth and maturation. They reflect changes perceived in the individual's inner sense of self as one transitions through these life milestones. So think about things like marriage, college graduation, career change, retirement. There are situational crises. These are crises that are directly linked to sudden onset, random, unexpected, unpredictable, uncommon, and environmentally triggered episodes. So the individual faces external events that may alter their life considerably and even permanently. These could be our health-related crises, loss of a body part, loss of function, major surgery, auto accident, life-threatening illness, death-related crises, loss of a loved one, crime-related crises, financial crises, things like that. There are existential crises. These crises are the result of personal anxieties and inner conflicts that are associated with significant and unresolved human issues and uncertainties. These typically reflect subjective concerns that include things like the purpose of life. What is the meaning of life? What's the meaning of existence? Issues of dependency versus independency. Freedom and freedom of choice, alienation, and connectedness to others. Talking about post-impact coping. Post-impact coping can best be seen as the person-level analog of community-based tertiary prevention, which embodies rehab philosophy and processes and focuses on reducing and altering functional limitations acquired in the most recent as well as remote past. Their resolution culminates in enhanced quality of life. Post-impact coping has been traditionally viewed as including two temporally variant coping efforts. These are proximal or reactive coping, where the impact of harm, damage, loss, and onset of CID has been sustained within recent time, and distal or residual coping efforts, where these events occurred more remotely in time. The more traditional view of coping fails to fully recognize two important issues, though. First, post-impact coping is not necessarily bound by a past-oriented psychological framework. And second, it does not originate from a loss and grief mentality. Two with post-impact coping efforts are not necessarily constricted in their focus to negative perceptions, cognitions, and feelings that are tied to lost past abilities and unfulfilled dreams. Indeed, adopting a future-oriented, positively valenced coping framework rather than a past-oriented, negatively valenced approach to coping negates focusing not only on the immutable past and therefore losses incurred, but also, and most importantly, on the future and its many opportunities for personal growth and improvement in one's quality of life. So, implications to rehab theory. The distinction between a past-oriented, negatively valenced, and present and or future-oriented, positively valenced approach to post-impact coping is also implicitly, if not always explicitly, portrayed in several of the leading models of psychosocial adaptation to CID. So what does any of this mean to us? I don't know that it means anything. Like their disengagement, mostly past-oriented post-impact coping modalities, post-impact engagement coping, active acceptance, problem-focusing planning, positive framing, seeking social support, and coping resources like hope, optimism, benefit, finding, meaning-making are mostly future-oriented. Disengagement coping efforts are, in general, oriented towards past events. For example, blaming self or others for CID onset focuses on irrevocably past losses and the reasons for their occurrence. Wish fulfillment can be equated with attempts to negate or nullify the reality of CID and avoiding confrontation with a realistic CID experienced future. In contrast, engagement coping and the use of positive coping resources are, in general, squarely anchored in present experiences and likewise view the future more favorably and as realistically changeable. Furthermore, whereas the former modalities largely dwell on the sustained losses and functional deficits or seek to negate their reality by adopting subterfuge mechanisms, the latter modalities focus on efforts that seek to build on remaining functions and available skills and resources. To kind of end things up, the field of vocational rehab is traditionally focused on helping people with CID seek and secure employment commensurate with their functional levels, skills, and abilities. Two pivotal concepts that have undergirded much of the success incurred by vocational rehab are those with strengthening client life skills and motivation level. As viewed from a post-impact, future-oriented, positively valence coping perspective, both concepts acquire additional meaning that can serve to further elucidate their importance and usefulness. Life skills have been operationalized as skills that include self-direction and determination skills, self-care skills, employment skills, work tolerance skills, and communication skills. These life skill things I think we can help to facilitate as we being the first individuals that may be working with somebody once they've had that CID. It's going to be us and the training that we do, the strengthening that we do, the development of their occupational skills, the things within occupational therapy, how to use their upper extremity function, etc., that are going to be the starting point for seeing where they can go with these other things here. Although post-impact coping strategies emanate from past traumatic events, they are by no means exclusively past-oriented and in fact often focus on presently encountered obstacles and barriers as well as anticipated future issues. Indeed, it is the latter coping orientation that's been often associated with successful psychosocial adaptation, better quality of life, and positive rehab outcomes. One area that the rehab researchers may wish to address in the future is the nature of the relationships between the coping strategies and psychosocial adaptation. Finally, skill acquisition discussion. Skill acquisition is normally associated with rehab efforts to compensate for the functional limitations imposed by CID through the enhancement of other, not directly implicated abilities and skills, thus often necessitating modification and reformulation of earlier life goals. So, again, kind of summarizing things here. Some of this information is stuff you're probably like, I don't care. Maybe this has no relevance to me. And I would agree with you on that. It probably has absolutely none, and that's perfectly fine. I think what the chapter is trying to get across is that one, people with chronic illness, chronic injury, and disease, these individuals are going to have their life altered in such a way that it's going to cause stress. It's going to cause a reaction, and they're going to have to learn how to deal with that. Okay, there's going to be coping that needs to occur. Obviously, with the way our healthcare system is and the skills that we have as PTs and OTs, we aren't involved in that, but we can serve a vital role of referring people to the right professionals and also recognize that if somebody is not performing at a level we might expect them to, there could be all of these psychological things going on.